everybody. Welcome back to This Week in Global Health, otherwise known as TWiGH, which is a regular video series that discusses relevant and current topics in global health. Today, we're going to start a special series featuring leading topics coming out of the latest publications from the Disease Control Priorities Network, starting with essential surgery and global surgical disease. I'm Jessica Taff, and I'm hosting this show today from the Washington, D.C. metro area. And to help discuss our topic today, I have my fellow TWiGH colleague, Solzhen, here, and two guest panelists who are experts on essential surgery. Now, everybody, why don't you introduce yourselves?
Hi, everyone. I am Solzhen Bali, and I'm joining you on a warm and sunny DC evening with Jessica as a co-host for this show.
Hey all, my name is Mark. I am joining you from a very cold Denver, Colorado. I am the research director for Harvard's program in global surgery and social change, and I was one of the authors on a few of the chapters in the DCP volume on essential surgery.
Me, Henry, and saying hello from Florida, and the founding executive director for the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, and also board member of the International Collaboration for Essential Surgeries. I'm happy to be here. Thank you.
Awesome, thanks. Well, Solzhen, before we dive into today's topic, I thought maybe you could give everybody a background on what the Disease Control Priorities Network is.
So basically, DCP3 is a third edition of Disease Control Priorities that is actually an up-to-date comprehensive review of the efficacy, effectiveness, and cost-effectiveness of priority health interventions that can help policymakers in priority setting and resource allocation to address global health challenges.
They publish these assessments in 9 volumes, and they're focused on the interventions for different disease areas, including essential surgery. And what I think was fantastic about it is that once the publications are actually published, they're all available online for free, and you can check them out at DCP3.org. Look, we're focusing on essential surgery today, because this is an important and emerging issue in global health that has really started to get attention. In fact, Paul Farmer and Jim Kim have called it the neglected stepchild of global health. Why it's tragic that it's neglected is that 2 billion people lack access to emergency and essential surgical care. And most of the gap is in rural and marginalized populations in low and middle income countries. And this is a real problem because a lack of surgical care just for simple treatable conditions can lead to serious and life-threatening conditions, or poor quality surgical care could actually lead to chronic disability that would affect someone's quality of life and their economic potential.
You know, while we're talking, it's also very important to define exactly what we mean by surgical disease, because even experts don't agree on one definition. And it can be quite confusing since some illnesses only become surgical disease when they're neglected long enough. So for example, very often essential surgical conditions need to meet the following criteria. Are they primarily or extensively treated by surgical procedures? Are there other care options? Do they have a large healthcare burden? Or can they successfully be treated or eliminated using a surgical intervention?
Yeah, I think this definition of surgery as things that can be treated with a surgical operation, things that have a large disease burden, and things that are primarily treated by surgical procedures is way too narrow. And I'll give you an example of why I think that. If I were to walk outside right now and slip and fall and hit my head, then I hit my head, lose consciousness, and then brought into the emergency room, I would be seen by a neurosurgeon, most likely. And most likely that neurosurgeon would decide to do nothing with me, even if there's blood inside my head, would just sort of wait to see what happens. And likely nothing would happen and I would not be treated surgically in that definition. But the only reason the neurosurgeon can do that is because she's got a fully staffed sort of surgical system behind her that she can treat me non-operatively. Now, does that mean that my brain bleed is considered a non-surgical disease? And I'd argue that it's not. It required the expertise of a surgeon, even if I never actually ended up in the operating room.
So I think it is important to define surgical disease for sure. And under that, even to go further and say, what do you mean by an essential surgical condition? And the DCP3 has really done a great job in terms of really saying, all right, these are primarily extensively treated by surgical procedures and other surgical care, have a large health burden, and can be successfully treated by surgical procedure. That's good, but it does exclude some other conditions by which, to some people's minds, it's non-surgical, but when you say surgery, it implies cutting, it implies manipulation, it implies a lot of things that is very invasive. And Mark has really aptly pointed out an example of one of those conditions.
The fact that it is so broad really is challenging, and the fact that people are bringing that up challenges our kind of binary way of looking at it. And so I want to ask Mark and Jaymie, why set it apart like this, as opposed to really instead just talking about increasing surgical capacity within all health conditions and all of global health?
We're not at all trying to set aside a subset of conditions that these are surgical conditions, because one of the most important things about surgery is that it is cross-cutting. It doesn't lend itself to a disease-specific group because it's a procedure, because it's a treatment as opposed to a disease. And we're focusing on scaling up surgery in that way because we really don't want to make the point that the world should focus on surgery instead of focusing on tuberculosis or instead of focusing on maternal health, but that the world should focus on surgery because we're not going to be able to achieve our maternal health goals if we don't actually scale up surgery in the entire hospital. We aren't going to be able to treat some really advanced forms of TB if we don't have surgical procedures. We're not going to be able to treat cancers, et cetera, et cetera. The list goes down. So surgical conditions aren't a separate disease entity at all. It's surgical treatment that is part of the health system that we're working on.
I think it's important to focus on surgical care as a separate disease entity, and that's because if we just stop now and look at the astonishing lack of progress in the rollout and scaling of surgical systems in the developing world in the last 40 years, you would see that there's some surgery is fundamentally different from everything else. And there's a reason why we need to focus on it as a separate entry. Separating out the simplest and the most basic of surgical procedures that everyone should have access to regardless of their ability to pay, really. And if you really, really narrow it down to a very, very focused set of interventions and show them that it's possible to provide that, then several things happen. First, you can't help but invest in the health system as a whole.
Definitely one of the myths is that the burden of disease due to surgical conditions is actually quite low. But as we've already been discussing, it really isn't. And it's not limited to just, specific health issues. I like that already we've touched on this and tried to dispel these myths, but there's a very large burden of disease, and that's primarily and extensively treated through surgery. And what the DCP volume on essential surgery has brought up is that if full provision of essential surgical conditions was given, that this could avert about 1.5 million deaths a year, or 6 to 7% of all avertable deaths in low and middle income countries.
Jess, since you mentioned the number of deaths essential surgical disease could avert, we should also describe what exactly are the essential surgical procedures. Things like dental procedures, like extractions, so important. Basic obstetric and family planning procedures like cesarean birth, vasectomies, fistula repair, general surgery, such as circumcision, appendectomy, hernia operations, and treating various types of injuries and congenital physical conditions are part of it. There are many more, in fact, in total 44. And what's most notable is that most of these could be done at first level or district hospitals, if not done at a community health center.
I'm going to be the naysayer here. That 6 to 7% estimate is also way too low. This comes from one paper that looks at exactly what you said, Jess. It looks at the number of avertable deaths from a limited set of surgical procedures at the first level hospital, which I agree with Jaymie is where we should start. But overall, that 6 to 7% number is essentially us telling the world, hey, 94% of your diseases don't need us. which I don't think any of us truly believe, that only 6% of patients that enter hospitals need surgery. And again, so if we go back to the definition that we were using before, which is a disease is surgical if surgical decision-making is required at some point, then that number jumps from 6 to 7% all the way up to 30%, which, you know, at least to me feels like a closer number to what reality is.
I think that the DCP3 estimate for the global burden of deaths that could be avertable by easily treatable conditions requiring surgical care while it is a good figure, I think it is an underestimate. So take, for example, the global burden of disease study, which cites that injury alone causes 5 million deaths per year. And we know that about 90% of those deaths are found in developing countries. And if you would think about, well, out of all those deaths, which of those are avertable? Let's say 40% are avertable, right? You're already having a 1.6 million number out there just from injury alone. So it probably is an underestimate, but I think it's a good, it's a good place to start with, to just start to uncover the magnitude. And if you think about it, that's just the tip of the iceberg, right? Underneath the deaths, where surgery really shines is in averting disability, right? Think of all, the kids born with cataracts that are blind, and you make them see, right? So I think that any figure that fails to really account for the amount of disability that surgery can avert is painfully inaccurate.
Another myth, right? So we were talking about, why haven't people been addressing surgery? Well, it's really hard and it's just daunting. And whether it's because, well, first of all, there's not enough people, but then we find out there's actually a lot of people that are affected by surgical conditions. So then the next thing is like, oh, well, just surgery in general is expensive. Therefore, it must be, if we have a lot of people that need surgery, that's going to be expensive. However, actually, this DCP3 volume suggests otherwise. It says that essential surgical procedures are among the most cost-effective of all health interventions.
This is a really, really good point. Surgery is very cost-effective, and I think the myth, quote unquote, that surgery is expensive is not a myth. Surgery can be really expensive to implement. However, it's not. It is expensive, but to say it's too expensive is to say that we're not getting enough value for what we're paying.
So the idea is that not only could it be, well, again, it's a myth that it could be hard to treat and very costly, but it actually, the other point is that it's not feasible in low resource settings for a lot of those reasons about just being difficult and costly. But again, this isn't true. There are many examples where their access to, capacity for, and the quality of care has been improved. But I want to ask Mark and Jaymie, what are other ways that you think we can increase access, and what do you think are some of the challenges with doing so?
I think task shifting, task sharing has a huge role in doing this, but getting to the cost effectiveness question of it and getting to the challenges that it faces. One of the challenges that it faces is that, and one of the things we haven't talked about really yet, is that even if surgery is cost effective, it may not be affordable for the individual patient. And as we roll out something like task shifting, as we roll out something like increasing the workforce, the surgical workforce in a country, we need to realize that that's going to draw out some demand for surgical services that patients may have that they couldn't get because there wasn't a surgeon there. But that surgeon, that task shifted provider, isn't free, and we may actually counterintuitively worsen the financial status of people who are getting surgery. So as we're rolling out these things, and we've done some research to show exactly that with task shifting, as we're rolling out these things, we need to keep in mind that medical interventions, surgical interventions, act on an axis of health, but they also act on an axis of financial risk to patients. So we need to make sure to keep both of those in mind.
I'll start by saying access to surgery has multiple dimensions. So when we think about it, we have to think about it in terms of the availability of surgery, affordability of surgery, accessibility, and attitudes towards surgery, which is, when you bundle it up, also can constitute really the significant barriers to surgical care. So for example, people think that in some places surgery is not happening, which is not true. There are surgical procedures that are happening. It's just that there are some people who are so hidden they're in the far-flung regions of a country that they can't get to where the surgery is happening, or they don't know that it is happening. So transportation and information on where this is happening, even contacts within the healthcare system, those are significant challenges. They just don't know how to access it from that standpoint.
My next question for you guys is, how do we increase capacity for surgery in low resource settings? And I know, Mark, you talked about task shifting, but in terms of training, a lot of countries, lower middle income countries have very limited surgeons. How can we increase capacity by increasing training? How is that feasible? Is there something being done on that?
I think the increasing capacity in countries is a huge question, Sultan. I think you're asking the exactly right question. And there are a number of innovative ways of doing this that are out there that are pioneered in certain countries. We don't necessarily have to replicate what we do in the US or the UK in another country. There are countries, Ecuador, for example, is a really good example. There's a group in Ecuador named Sinter Andes that has trucks, and they go into sort of the hinterlands of Ecuador, where people like Jaymie was describing that really can't leave their farms, can't access surgery. Well, they bring the entire surgical ecosystem to them. Zambia does the same. There are NGOs that do this. Orbis does this in ophthalmology. Mercy Ships does this for 7 different procedures. So yes, we absolutely need to increase the manpower, but that takes a long time. And in the interim, there are a number of innovative ways that we can think about getting surgery to people who don't otherwise have it while we're training the surgeons.
Is there anything that you want to say about this issue that we haven't covered already that you think we need to really drive home at this point?
The last thing that I want to say is surgery has been some of the myths we've been talking about. Surgery has been viewed to be such this complex thing to do and such a hard thing to do, and it's because you literally have to bring the means of production of surgery to the individual patient, and so you have an entire ecosystem that you have to build up, which is true, but which is exactly the reason to be doing it. Because when we start doing that, when we start building up this ecosystem, we've built up the electricity, the water, the sterilization, the training, everything that we need to do in a hospital. So it is, in global health speak, it is the quintessential horizontal intervention, because we've got to do everything to fix surgery, which makes it also a really exciting place to be working.
I think this is an exciting time for surgery, where this is surgery, essential surgery, global surgery has never been in this space before, and we have the potential to sit alongside, right, the HIV, TB, malaria, sort of big group, because it is important, and I'm excited to be kind of alongside you guys, working on this together. So thank you.
I want to say thank you, Mark and Jaymie, for joining us. Your passion about this issue is just so evident, and it's, that's what inspires people to do things. And if you want to learn more about this issue, you can read the volume, the DCP3 volume, that is available at www.dcp3-org. And if you want to watch any more of our videos, we're going to be doing a whole series on the different issues covered by the DCP3 volumes. So tune in. We have our own YouTube channel at This Week in Global Health, and we invite you, especially if you really have enjoyed the topic, to comment on our videos, raise some questions, join into the discussion, or you can even tweet at us. And we all have our Twitter handles up there, so please do so. We love hearing from our audience. And please subscribe to our YouTube channel. That way you can get updates on what's coming up and the newest videos. But you can find us on our webpage as well. And there's a number of other places where you can find us and learn more about This Week in Global Health, like LinkedIn, Twitter, and Facebook, and Instagram. And we even have a blog. So, oh yeah, and then one more thing. So if you're really more of a listener rather than a watcher, we also have an audio podcast. And so we'll have the whole discussion of this episode on that as well. So again, thank you for listening. Thank you for watching. Thank you, Jaymie, Mark, and Sultan, for joining me tonight. And we will see you next time.